lipid accumulation product as a surrogate marker of insulin resistance. Insulin resistance is defined clinically as the inability of a known quantity of exogenous or endogenous insulin to increase the glucose uptake and utilization in an individual as much as it does in a normal population. It occurs as part of a cluster of cardiovascular metabolic abnormalities, commonly referred to as the insulin resistance syndrome or the metabolic syndrome. Insulin resistance should be diagnosed and treated with specific drugs to improve the insulin action. Insulin resistance is measured by a gold standard, which is impractical, and hence surrogate markers such as quantitative insulin sensitivity check index, QUICkie, and hemostasis model assessment estimated insulin resistance, HOMA-IR, are used to assess insulin resistance. In our study, we explored the possibility of utilizing lipid accumulation product calculated from triglyceride levels and weight circumference as a surrogate marker for insulin resistance. The need for the study. So insulin resistance syndrome involves a cluster of abnormalities that can lead to the development of type 2 diabetes, accelerated atherosclerosis, hypertension, as well as polycystic ovarian syndrome, depending upon the genetic background of the individual developing the insulin resistance. Insulin resistance determination with the HOMA-IR and QUICkie requires fasting insulin estimation, which may not be available in all healthcare centers. In our study, we explored the possibility of utilizing the surrogate marker LAC, lipid accumulation product, which is calculated from triglyceride levels and weight circumference as a measure of insulin resistance, which can be beneficial in a resource-poor setting. The objectives of our study: to estimate the fasting glucose, serum triglycerides, fasting insulin in apparently healthy and obese participants, to calculate and compare insulin resistance using fasting insulin, LAC, HOMA-IR, and QUICkie formula. The materials and methods used. A study was an observational, analytical, cross-sectional prospective study which was conducted out from the Institutional Ethics Review Board. The participants that we included were between the ages of 18 to 60 years of either gender attending the general medicine OPD. Our inclusion criteria was apparently healthy individuals, which we termed as Group A, and obese individuals termed as Group B, based on the BMI. Exclusion criteria were pregnancy, diabetes mellitus, cancer, chronic inflammatory disease, renal disease, liver disease, or rheumatic disease. History of current steroid medication or other drugs affecting lipid metabolism within 3 months. 60 individuals of either gender were recruited for the study based on the above criteria after obtaining informed consent and divided into 2 study groups. Group A, healthy individuals 13 number. Group B, obese individuals 13 number. The type of sampling done was convenient. The sample size calculation was based on the study by Amrita Bakshi, and her sample size was derived as 20 in each group, with a 5% level of significance and 80% power. To improve the power of our study, we set our sample size at 30 for both groups. The sample size formula is given here. Data collected: demographic data, name, age, gender, anthropometric, which included height, weight, and waist circumference. Biochemical parameters analyzed for fasting plasma insulin by chemiluminescent microparticle immunoassay, serum fasting triglyceride by glycerol phosphate oxidase method, and fasting glucose by hexokinase G6PD method using Architect CI8200 integrated automatic analyzer for diagnostics. Indices calculated were LAB, HOMA-IR score, and QUICkie score. The formulae for the 3 scores are given. Obesity, as an operational definition, is a non-communicable disease with excessive fat accumulation leading to a health risk. In this case, the body mass index or BMI is greater than or equal to 30 kg per meter square. Insulin resistance as a surrogate marker is defined as fasting insulin more than 10.57 microunits per ml, HOMA-IR score of greater than 1.97, QUICkie score of less than 0.33, and MAP score of greater than 48.09 in men and greater than 31.77 in women. The IR categorization was based on HOMA-IR in our study. The statistical analysis, descriptive statistics was done, and the biochemical parameters and acrobatic measurements were described as mean plus or minus SD for normally distributed values and median in the interquartile range for not normally distributed values. HOMA IR, lab, and Wiki. These are the results obtained. In this table, it shows the characteristics of the study population, the age group, BMI, waist circumference, fasting insulin, triglyceride, and fasting glucose all were in normal distribution, which is why they were represented as mean plus or minus SD, whereas lab, HOMA IR, and Wiki scores were of not normal distribution, which is why they were represented as a median and interquartile range. Comparison of fasting insulin, lab, HOMA IR, and Wiki. HOMA IR is considered for categorizing IR with a cutoff greater than 1.97. Fasting insulin as a marker of insulin resistance. In healthy individuals, fasting insulin had an 80% sensitivity in picking up IR with 100% specificity. In obese individuals, fasting insulin had a 92.3% sensitivity in picking up IR with 100% specificity. Lab as a marker of IR. In healthy individuals, lab had an 80% sensitivity in picking up IR with 20% specificity. In obese individuals, lab had a 64% sensitivity in picking up IR with an 83.3% specificity. Quickie as a marker of IR. In healthy as well as in obese individuals, Quickie was not helpful in identifying IR in our study population. The discussion. Insulin resistance, as you propose, is a primary cause in diabetes mellitus type 2, obesity, cancer, hypertension, and autoimmune disorders. When identified early, can be treated as well as monitored. Obesity, with increasing worldwide prevalence in the population, not only causes severe harm to the individual health, but also imposes a considerable burden on healthcare. In our study, we propose a cost-effective tool to measure insulin resistance in the form of lab, which is a surrogate marker. There are three categories of insulin markers: glucose loading, insulin loading, combined glucose and insulin loading. Markers that address IR in a steady state without a glucose or insulin intervention, indirect markers that correlate with IR such as ferritin, insulin and growth factor, binding protein 1. We are exploring the second group. The gold standard for calculation is hyperinsulinic euglycemic trap, which is expensive, labor intensive, and not available for all healthcare centers. Fasting insulin is not estimated in all healthcare centers because of the lack of standardization in assay procedures. HOMA IR and Wiki, though minimally invasive, required insulin estimation, and the values for HOMA IR are given below by the study by D et al. 1.97. Marino T et al. Show that labs are powerful tool in the study for metabolic syndrome based on the 768 Spanish adults with a bootstrap, 20,000 bootstrap level. Lab is based on a combination of base circumference and triglyceride that tends to increase with age. Limitation of the study is a small sample size, limited financial support. We could manage the raw sample size, lack of post-standard verifier values, no standard protocol for base and base circumference, except for the bilateral ASIs. Lab can be measured. A conclusion is lab can be used as a measure of IR in obese individuals in a resource poor setting. I would like to place on record my gratitude to RGOHS for supporting the study under short-term undergraduate research grant. I would also like to thank Mr. John Michael's statistician for helping in the statistical analysis. Thank you for the opportunity. So currently in a tertiary care hospital, they use fasting insulin as a marker. And HOMA IR and Wiki are calculated with a predominance being fasting insulin, because fasting insulin is a part of the formula to calculate HOMA IR and Wiki.
One thing is like, it is the cost for diabetes. Maybe like after some type of treatment, they develop higher. So it's not like primary cause for diabetes. After diabetes, they be on treatment. And because of these chronic metabolic factors and obesity, this so maybe you need to change them. Diabetes itself is the primary cause.
So, but we're trying to see in pre-diabetic that diabetes is our exclusion criteria, because we're trying to identify in non-diabetic individuals that what is their risk factor for metabolic syndrome using lab. Because most diabetic individuals do develop insulin resistance.
Did you follow the patients after a year? Because they informed that these were the values for them?
Yes, sir. They were all informed about their values because all of them wanted to know the results of the study.
What was the outcome? You didn't follow. You didn't follow it?
No, sir. It's not a cohort study, sir. This is not a cohort study. This is a cross-sectional study. So, which is why we're just taking in advantage of time to be studied.
Study again. What is the gold standard for insulin resistance? procedure that has to be done? What is the statistical analysis that has to be done?
To compare,
Yes. With the gold standard, you have to compare and say that this can also be used as a marker, which you have included here. Lab can be used as a measure of IR. Is the conclusion that you have done.
Yes.
For that, what is your statistical difference?
we compared it to HOMA IR.
Now, what is the sensitivity, specificity?
It's
Positive predictive value. No, you have told only sensitivity and specificity. Please go back to that slide. Please 63 or something I saw. 80.
Yes, this one.
Yeah, 64.
64.
In obese inclusions, lab had 64 sensitivity in picking up IR. What does it mean? Can you infer this statement? And 83.3% specificity. Second question is, based on this, can you use lab as a marker? And if you use, what may be the problem that you may face in clinical practice?
Okay. For sensitivity.
You got my question?
Yes, sir. So sensitivity is, let's say there's a population of 100 people who are insulin resistant. Lab can pick up 64 of these 100 people accurately. That is why it's 64% sensitivity. And the specificity is the number of people it picks up, 83.3% of them are insulin resistant. That means they're true positives.
Now, if you use this marker, what is the problem? Because is it enough? Is the sensitivity enough? Is the question.
So
We
even
have guidelines, international guidelines, to label something as a clinical marker so that it is routinely implemented in clinical protocol. What is the accepted cutoff of sensitivity and specificity?
so lab can only be used in obese individuals in this case because as we can see in healthy individuals, even though it has a high sensitivity, it has a very low specificity. Whereas in obese, it has a comparable sensitivity and specificity to HOMA IR.
That's very clear.
Finally, yes, sir.
Okay, how do you want to take this further? What is the laboratory task what we use in
Insulin resistance is in a tertiary care hospital. Okay. It's 650 in our hospital, sir, to do insulin resistance. And lab, since it only takes one parameter of lipid products, which is just triglycerides. Triglycerides on its own is I think 110, 115 in our hospital. So I think that would be a better marker, especially in resource poor settings, because fasting insulin has this chemi-immunorescence assay, which is available only in tertiary care hospitals, not in the primary healthcare centers. Thank you, sir.